My name is Matthew Harris, and welcome to my case study presentation on Grace, a 70-year-old female who suffers from congestive heart failure. Grace was diagnosed with congestive heart failure following an acute myocardial infarction in 2014, where flow was re-established with a double coronary artery bypass graft. Testing shows her heart failure to be with reduced ejection fraction in the moderate risk category, with the left ventricle ejection fraction of 38%. She also has a resting blood pressure of 130/68, placing her in the high to normal range, showing signs of mild hypertension. She also has an ischemic threshold of 110 beats a minute. It is important to monitor her heart rate throughout the session to ensure she does not reach this. She showed a peak VO2 of 15.5 milligrams per kilogram per minute. Most research indicates this to be a poor reading. However, research conducted by Lund and Manzini specifically delves into VO2 for patients with heart failure, and this indicates Grace's peak VO2 to be in the average range for females her age who are suffering from heart failure. There are several important considerations for Grace when exercising. It is important to ensure that she exercises 10 to 15 beats per minute below her ischemic threshold to avoid the onset of angina. It is also important to check her blood pressure at the start of exercise for changes. However, over-monitoring things such as blood pressure or her ECG during exercise may exacerbate feelings of anxiety around exercise. It is also important to note potential amotivation for Grace due to her lack of fitness and sedentary lifestyle after retirement and diagnosis of heart failure. There are several medications that are important for Grace in the management of heart failure. Short-acting nitrates are vital for her, and we must ensure that she has these handy before we commence exercise. They are the primary mechanism of managing angina attacks and should be administered immediately should the onset of angina occur during the exercise session. ACE inhibitors are useful in the management of hypertension, as they assist in reducing blood pressure by blocking the release of angiotensin-converting enzyme, which produces angiotensin II, which in turn narrows the blood vessels and increases blood pressure. ACE inhibitors do, however, increase the risk of hypertensive events during exercise, and as such, it is important to monitor her for signs and symptoms and check her blood pressure if needed, as well as perform a thorough warm-up and cool-down in each session. Thiazides assist in reducing blood pressure by increasing sodium and water excretion in the kidneys, and may lead to electrolyte imbalances and dehydration. As such, it is important to monitor for signs of this and ensure Grace is hydrating effectively both before exercise and throughout. Beta blockers are a common blood pressure medication that slows the heart rate, reducing cardiac output, which in turn reduces blood pressure. However, due to the low heart rate of the patient, false senses of exercise intensity often occur when using heart rate to prescribe, and as such, perceived exertion scales should be used as an alternative. It is, however, vital to continue monitoring Grace's heart rate throughout to ensure that she remains the 10 to 15 beats per minute below her ischemic threshold. In this case, it may be useful to prescribe exercise using both heart rate measures and perceived exertion to ensure that exercise is both safe and effective for her. There are several goals we would like to meet for Grace based on her referral. Goals supplied are broad and include improving heart failure symptoms and improving her ability to perform activities of daily living. Both of these can be improved through exercise, meeting recommendations focusing on improving aerobic capacity and strength to perform these activities. Further goals can be made based off her subjective history, including improving her aerobic capacity to allow her to begin walking in the park and gardening, as these are activities that she used to enjoy, however, is unable to perform these now due to fatigue, as well as reducing her resting blood pressure to relieve symptoms of hypertension. There are also some additional tests that I would like to perform with Grace, including a 6-minute walk test and estimated 1RM testing, as these will assist in providing effective intensities when prescribing exercise. Estimated 1RM is an appropriate test for this client, as the lower loads are likely to improve her confidence and allow her to exercise safely. According to guidelines by Vidicchio et al. In 2023, warm-ups for cardio rehab patients should be thorough and progressive, building up from a low intensity to an intensity of approximately 12 out of 20 RPE. This is to ensure that they are fully prepared for the session and are and reduces the risk of hypertensive or cardiac events. The main aerobic component of Grace's session is treadmill walking. This aligns with the goals we've set for her to get her back to walking in the park, and we would ideally like to perform this as moderate intensity continuous exercise. However, she is unlikely to be able to perform continuous exercise for a long period of time to begin with, due to her lack of conditioning. So we will start with moderate intensity intervals, starting with 5 minutes of walking at moderate intensity, followed by short rest to allow her time to recover. As discussed earlier, performing a 6-minute walk test will allow us to identify her fitness level in a more practical sense, with results assisting us to prescribe both intensity and duration of each interval in a manner that is effective for her. This will be progressed over time by reducing the amount of rest and increasing the time she is walking until she is able to perform the walk continuously. Evidence suggests aerobic exercise sessions should be performed for a minimum of 30 minutes for clients suffering from heart failure. And as such, we will aim to build her tolerance over the 8-week period to allow her to meet this recommendation. This will be performed 5 days per week in order to meet the minimum recommendation of 150 minutes of aerobic exercise per week, with the time in each session progressing to meet the ideal range of 210 minutes or more per week. Resistance training sessions, according to research, should be conducted over a time of greater than 20 minutes. Exercises should initially be simple, using large muscle groups bilaterally to allow Grace to develop confidence and understanding of the exercises in a way that is safe and easy to understand. Using a tempo that is focused on the eccentric phase with a 3-second eccentric followed by a 1-second concentric phase allows us to develop the greatest benefit for cardiac rehab patients. On top of this, isometrics have been proven to be an effective method of reducing blood pressure and should be performed using 4 sets of 2 minutes with a 2-minute rest between sets. This will initially be done using a leg extension isometric for the lower body, as this allows us to provide load safely and effectively. This will be progressed over time, over the 8-week period, aiming to be performing a wall sit at the end should her tolerance allow it. Ideally, we would like to perform additional tests before the commencement of her exercise program, including estimated 1RM testing in both chest press and goblet squat, to allow us to appropriately prescribe load so that it is challenging for Grace while still being safe. Similar to the warm-up, a cooldown should be extended and show a gradual easing of exercise in order to elicit healthy blood pressure and heart rate responses from exercise. Research suggests that gradual progression of aerobic exercise is essential for patients suffering from heart failure. Increasing duration to meet 30 minutes per session should be the first priority. Progression of resistance exercise is also essential, progressing volume and intensity before progressing frequency and the type of training. This is done over the period of the 8 weeks, with exercise beginning to become more difficult during the last 2 weeks. This is seen in the lower body isometric, progressing from leg extension into a wall sit. This should be adjudged based on Grace's tolerance and can be regressed back to leg extensions, progressing the load she is using until a wall sit is tolerable. Similarly, both the chest press and goblet squat have become slightly more challenging for her over the 8 weeks, creating a sense of variety, as well as progression for Grace. An effective method of starting to introduce exercise to Grace, particularly at home, is exercise snacking. Research conducted by Ju et al. In 2024 suggests that this is an effective method of introducing exercise for older adults and involves breaking exercise down into small sessions throughout the day, allowing her to perform the required volume while ensuring it remains tolerable. Here is a summary of the progression over the 8-week program. This shows the gradual increase in time for each aerobic interval, as well as the decrease in rest time, progressing towards continuing for the entire 30-minute plus duration in each session in the last 2 weeks. It also shows the progression of resistance sessions over time, introducing a third at-home session each week. Progressing the duration of aerobic exercise to meet the guidelines is important in heart failure patients. Before progressing intensity. Increases of 5 to 10% every 1 to 2 weeks in both duration and intensity typically have been shown to be well tolerated within these patients once the total recommendation of time has been met. Thank you for watching my case study presentation on Grace suffering from coronary heart failure. I hope you found it both engaging and informative.